you will have noticed through with our PhDs who present that every one of them is actually undertaking mixed methods research, and qualitative research is really important to understand what's required for behavioural change and improving judicious use of antibiotics. So welcome, Jaclyn, and we look forward to hearing about your latest work.
Thank you, Kaz, and again extend my welcome to everyone that's listening on the webinar. So today I'll be speaking about some qualitative research that we've undertaken in regards to antimicrobial stewardship in regional, rural and remote hospitals, and we've titled this Listening to the Coalface Clinicians. Just like to acknowledge my PhD supervisors, in particular Tom Schulz, who was heavily involved in this qualitative research. So the research that we've been doing around regional, rural and remote hospitals and AMS, we've got 3 preliminary projects that we've been working through. So I'll just recap those just so you have a feel of where the research is going. So the first one was analysing the hospital NAPS survey, the hospital NAPS data to see if there are any similarities or differences between antimicrobial prescribing practices in regional hospitals versus major city hospitals. And that work has concluded, and there's been some interesting findings that have come through. So essentially there was a higher rate of inappropriate antimicrobial prescribing in regional hospitals compared to major city hospitals, although the difference in raw figure numbers wasn't particularly large. However, another key finding that came out of that work was that there is certainly a number of high-risk infections that are being treated in regional hospitals, and that there was a difference in the appropriateness of antimicrobial prescribing choices between the major city and the regional hospitals, in that the regional hospitals appeared to be making poorer choices in the treatment of high-risk infections such as sepsis. So some of that information has been presented previously, and I know that there's a lot of work being done in the area of sepsis at the moment, both here in Victoria and also through the Clinical Excellence Commission in New South Wales, so I look forward to hearing more about that work into the future. Project 2 is what I'll be discussing today, which was exploring barriers and enablers for AMS programs in Australian regional hospitals. And Project 3 is also underway at the moment, and that's a series of key informant interviews. So really wanting to speak to some of the innovators in antimicrobial stewardship across the country and find out what they're doing, what's worked well, and what we can learn from their experiences so far. So we've done 14 key informant interviews from clinicians from every state in Australia, and we're in the process of analysing that information at the moment and hope that that will be complementary to the information that I present to you today. So an outline of the presentation, I'll explain the methodology of this study, describe who the participants were and where they've come from, highlight a couple of key themes that are particularly applicable to antimicrobial stewardship. As you can imagine, there's a number of issues that clinicians working in regional and rural areas face when providing healthcare, and I've tried to pull out the ones that I think are particularly interesting or particularly relevant to management of infectious diseases. I will propose some potential strategies to support AMS in regional hospitals that leverage or address those key themes. And I do want to point out at this point in time that they are just ideas and suggestions, and they're not something that we've sat down and worked through in terms of what's going to be feasible, what's going to have the largest impact. But I certainly would like feedback from the group here today, people online either through the webinar or afterwards via email or Twitter, if that's your medium, just to let me know what you think about some of these ideas. But also acknowledge that there are a number of challenges, and again, we haven't come up with the solutions for those challenges. So really today is just acknowledging those and how they might impact on some of the strategies. So the aim of this research was to analyse the insights of coalface clinicians who work with AMS programs in Australia, regional, rural and remote hospitals. And from now on, I'll just refer to them as regional hospitals just because it rolls off the tongue a little bit easier. But of course, acknowledging that the regional hospitals vary from quite large regional city hospitals down to quite small facilities. But I will use that term today just for ease of speech. And really we wanted to find out what are the enablers for AMS in that setting and what are the barriers that still remain. Acknowledging that national standards accreditation has made a difference in terms of AMS impact across all hospitals that are required to be accredited, as well as the clinical care standard through the Commission as well. So with all those tools and resources and drivers in place, what's worked well and what are the barriers that still remain, and what else is needed based on the experiences of these coal-face clinicians. So the study was approved through Melbourne Health as a quality assurance program. It was a qualitative methodology, so we used focus group methodology, although we were able to do individual interviews if there was a particular person that wasn't able to attend a focus group and we thought that they were particularly important to speak to. We used purposive sampling, so we directly approached people that we thought would be able to make a contribution to the research, and we did that through a number of different methods. So we used the NCAS website, we used research contacts through NCAS, professional affiliations, discussion boards such as the ID cost discussion board that's hosted by the Society of Hospital Pharmacists in Australia. And then we also used snowball sampling as well. So there were some occasions where someone was invited to a focus group and they said, oh, can I bring my infection control nurse along as well, because I think they'll be interested in contributing. So there was that ability to include participants through referral methods. The focus groups were conducted and we undertook a transcription process for the discussions, and then those transcripts were reviewed using a standard coding process to identify core themes. Okay, thank you. After that drum roll and that nice pause there, here are the results. So in terms of the participants, I just thought I'd outline who it was that was involved. So in total, there were 22 participants that were involved across 4 focus groups and 1 individual interview. The breakdown of the professions are shown on the first part of that graph there. So there were 8 pharmacists involved, 6 clinicians who were either infectious diseases, physicians or microbiologists or both, infection control practitioners or nurses, 3 of those, but the clinical administration that I've mentioned at the bottom there, 2, both of those were from a nursing background. So you could say that the nursing input was 5 participants, and then we did have 3 general practitioners that were involved, 2 of those in a very cosy focus group of 2 people, and 1 who undertook an individual interview. 3 GPs is a much lower number than the number of 8 pharmacists that we had involved. However, both Tom and my impression of the information that we received from those, that it was quite consistent. We felt as though that we weren't going to achieve a lot by trying to recruit a huge number of more GPs, and it was particularly difficult to recruit the 3 that we'd gotten. So we were happy with the information that had come through. In terms of the state-by-state distribution, there is a bit of a predominance there of Victorian representatives, and that's probably a reflection of my physical location and that we had a physical face-to-face focus group available. Some participants from New South Wales, ACT, Queensland and WA. SA and Northern Territory and Tassie were absent from the focus groups. However, I do want to point out that both of those states were represented in the key informant interviews that we've undertaken. So their input certainly has been received through that particular piece of research. So we're happy that they were able to participate in that particular aspect, but didn't have anyone that volunteered themselves for the focus groups. So as I mentioned, there were 4 focus groups and 1 individual interview. The first focus group was held face-to-face with 8 participants, and that was actually a mixture of pharmacists and infection control or nursing staff. The second focus group was a mixed focus group where we had a number of people in the room, them being infectious diseases physicians or microbiologists, but we also had a number of participants that dialed in and participated as a mixed group. So there were 6 in that group. There was a remote pharmacist group where there were 5 participants that were all involved via teleconference, 2 GPs via video conference, and then 1 GP by individual interview. So I'd now just like to go through a couple of the themes that have come from the research, and as I mentioned earlier, these ones are hopefully particularly relevant to infectious diseases. There's a lot more information that was contributed by the focus group participants, so I thank them for all of their information, and we certainly will hold on to that. But today there's about 4 themes that I wanted to speak to about today. So the first one that came through from the discussions was really about a culture of independence amongst regional clinicians. So this was both GPs, so in smaller regional hospitals, the services there can be provided almost exclusively by GPs. Even in some larger regional hospitals, there may only be 1 or 2 staff clinicians that are working within those hospitals. So there certainly was a need for them to be able to work independently, because that's just the reality of the environment that they're in. But certainly acknowledging that autonomy that GPs in particular have can be challenging when you're trying to influence prescribing behaviours. So the quote there from the focus group was that the GPs are used to making their own decisions, and they're quite comfortable with that because they have to do it every day to make sure that they're able to provide the services that they do in the environment that they do. There's also an acknowledgement that in that environment where you are working potentially as an independent GP servicing the hospital or within a small group of clinicians, that there's less opportunity for peer feedback. And being much less opportunity than there would be if you were working in a metropolitan hospital with a large team of clinicians. The feedback that was provided, the example that was described in the focus group, although it was the GP receiving feedback on their antimicrobial prescribing in terms of their actual general practice arm, so not their hospital prescribing, was that the information or the feedback they were given was definitely rationalised. So the quote that came out of the focus group was that if I did well, I pat myself on the back, and if I didn't, I just ignore it and put it away somewhere. So the feedback really from the GPs was that it had very little impact on changing their behaviour. So it's just something for us to think about in terms of how the feedback's provided and how to make sure that it actually changes behaviour rather than just being put aside. The other thing that came out on this theme of independence amongst regional clinicians was an insider-outsider phenomenon. So really very much the people that live in the regional towns and small towns are very invested in their community and very invested in the outcomes and health of the community, and they really needed to feel that the people that were coming and providing advice to them, either physically flying in, flying out, or providing that advice remotely, were also invested in that community, and that it took time for that trust to be built. And once that trust and those relationships were built, then they were much more willing to accept the advice of someone who was providing that advice remotely or from a sessional perspective. So the quote there is that I'm making more headway now that they know who I am and that I'm repeatedly turning up. So it's certainly something that they were interested in, people that would stick around and be more willing to take advice. So some other quotes from the research were that quite often people would fly in, fly out, and that's just an expression for people sort of coming and going, not necessarily flying, but they never came back again. They came once and never came back again. And at least it's me every time that's coming. So they really wanted to see an investment in their community by the clinicians that are providing this advice. So in terms of potential strategies that could be adopted or are leveraged around this theme, I think particularly relationship building seems to be really, really important to the communities, and around consistent staff, that it's the same face or the same couple of faces that they're dealing with each time. Reducing professional isolation is certainly something that's been acknowledged in regional communities or regional healthcare, and how can that be addressed both for the people living in the community, but potentially also for those that are providing a remote service. How do you make sure that they're supported as well and are able to provide the service in a way that's professionally satisfying for them as well? And then suitable benchmarking or feedback. How do you provide that potentially to a GP that's seeing only a couple of patients in quite a small hospital? What's really going to work best for them, and what's going to be something that's actually going to influence their prescribing choices? So in terms of challenges, influencing GP prescribing, as I've mentioned, independent practitioners working essentially within private practice. Excuse me. Staff turnover can be a problem, and not only from the people providing the service, but within the communities as well. So how do you maintain those relationships if the staff at the small hospital are also changing over quite frequently? And as much as it's a strategy, I've also put it in the challenges around suitable benchmarking and feedback. That certainly came up in the focus group as something that people were struggling. with, whether that's around contributing to NORS, whether that's contributing to NAPS, or another forum where they're able to get some of that feedback on their practices. So the second one to talk about is the impact of geographical location and how that impacts on services. So there was a lot of discussion within the focus groups about the fact that your location can impact on the type of care that you receive, and certainly the Atlas of Healthcare Variation that's released by the Commission certainly reinforces that there's different healthcare outcomes and different services provided depending on where you live. The first one there was around choice of therapy and where you're located or where you're receiving the service, that the clinicians there, their choice of therapy can be impacted by that location. So the first quote there was around access to therapeutic drug monitoring. So 47% MRSA in this particular community, and that the prescribers there were under the assumption the vancomycin is too hard to use simply because they don't have therapeutic drug monitoring. So making choices based around the access that you have to certain monitoring or other services within your community. Another pharmacist that was involved in the discussion group also acknowledged that potentially that is a real problem, that they're not able to get access to pathology results over weekends. So if someone is due to have their levels measured on a weekend, that they're not able to access those results until the weekdays that precede that. The other message there was around microbiology results, and it certainly has come up quite a bit through the focus groups and also the key informant interviews, was at least a perceived delay in access to microbiology results, purely because of the distance that some of these communities are from the centres that are processing the pathology or microbiology results. So that there'll be one time in the day where the particular pickup happens for pathology results, and if you miss that pickup, there's not another pickup till the next day, having to use buses, planes, couriers, lots of different ways of trying to get the pathology results to the centre that's processing them and getting that information back again. So the quote there from an ID physician was that principles such as needing to review microbiology within 48 to 72 hours and the therapy is a message that might not resonate quite as well with people that work in rural areas because of those delays, and potentially those messages may need to be adjusted, or thinking about other ways that that can be made practical for what they're working with. So in terms of some strategies, point of care testing is certainly something that's talked about in terms of being able to make the microbiology results available more quickly to people living in those more remote communities. There's obviously pros and cons of that, and you need to make sure that the point of care testing is appropriate and that's being interpreted appropriately by the people performing the test. So that's something for consideration. And potentially reviewing the therapeutic drug monitoring recommendations. So have they been designed for people or clinicians in metropolitan centres or large regional cities who have access to quick turnaround for therapeutic drug monitoring? But is there something else that could work and be safe for people that work in regional centres that don't have access to that information quite as quickly? So again, that's something that would need to be explored in terms of the evidence that exists for those recommendations at this point in time. The challenges that I see are the reality of distance, that especially somewhere like WA, places and towns are as far away as they are, and you can't get something from A to B, in 2 seconds. So that's just a reality that of where people are located. And the challenge also could be confusing AMS messages. So if we say you work in a city hospital and you have to do microbiology within 24 hours, but if you live in a rural area, you don't have to do it because it's so delayed, etc., etc. I think there's a lot of potential for confusing AMS messages there, so that would need to be very carefully looked at. The third theme that came across was really the need to understand the local environment, and particularly this is around resistance patterns and acknowledgement that resistance patterns do vary quite significantly. So they can vary between states, but they can also vary within states. So the information that was provided from one of the participants was that within Queensland you can go from a 6% MRSA rate in one region to up to 47% in another region of Queensland. So how do clinicians access that information? How do they use that to make the most appropriate antimicrobial choices. So the quote that's up there at the moment is certainly around the ability to provide remote advice, acknowledging that you're not going to have an ID physician in every one of these small hospitals, and that service is more than likely going to be provided remotely. But acknowledgement that potentially when you're calling a tertiary institution for advice around infectious diseases, that they may not have the information that they need to be able to make an appropriate decision on what the best therapy would be, because they don't have access to the antibiogram for that smaller hospital, or they don't understand that the antibiogram potentially may be different in that particular region. So in terms of strategies, potentially the antibiograms need to be more readily available, and potentially a central repository of information about local areas may be of value. Also potentially formalisation of some of the relationships. So the discussion from the focus groups was that quite a lot of the relationships that are in place are informal, and that people are just calling the hospital that they did their training at, or a hospital that they're meant to be affiliated with, but there's no formal relationship around that infectious diseases advice or AMS advice. So potentially formalisation of some of those relationships means that you could build in some of these requirements, that you've got access to the antibiogram, or that you understand resistance patterns in that particular facility or facilities that you're providing that advice to. Some of the challenges that exist that I think are worth highlighting is that providing advice remotely in infectious diseases can be more complicated than some other conditions. So if you were providing advice remotely for someone who's got heart failure, you don't really need to take into account the things that you need to take into account regarding resistance patterns and whether a particular medications is going to work or not. It's quite different. You'd follow the standard heart failure protocol, and as long as you've got the information about the patient you need, you'd be fairly confident with providing that advice. But infectious diseases is certainly more complex when you've got that variability in resistance. And as I've mentioned previously, just the great variability that exists across such a vast country as ours. So the last theme that I wanted to mention today was around a concept of whether AMS is a competing priority for people, or whether AMS is really core business and something that just should happen as part of day-to-day practice. So the quotes on the first slide here really reflect an approach that AMS is something different and it's something extra that staff are having to do. And most of the quotes and the discussions around the impact on pharmacists who are very much involved in AMS programs in the regional hospitals, whether it's a pharmacy service, of course acknowledging that there are some small hospitals that would be infection control practitioner responsibility where most of that workload would fall. But it's acknowledging that pharmacists need to be available and interested, having adequate time and being funded for their time certainly suggests that the approach would be that you need extra FTE to be able to provide AMS in those facilities. The second quote there is really just highlighting that AMS, potentially if you're doing a great job of that, it may be at the expense of something else, so that you're not able to do all your medication reconciliation or your chart reviews that would also be expected from a pharmacy service. So indicating that potentially it's a competing priority for other aspects of clinical care. The flip side to that is that AMS is core business, and the infectious diseases physician there's quoted that they're trying to frame it with their pharmacists that this is just something that, like you do every day when you're reviewing a medication chart, it's pharmaceutical review, you just need to think about it slightly differently. So we're not asking you to do something extra, we're just hoping that you can incorporate this into your daily practice. The second quote there was from a pharmacist who described their AMS program, and particularly around this concept of having multiple pharmacists that were able to provide antimicrobial advice where required, and felt confident and comfortable doing that for each and every one of their patients. So they felt like they were skilled up. If people went on leave, there wasn't a massive gap where there wasn't someone available to provide advice or have input into that patient care. So there were definitely different views on where AMS should sit, but potentially a strategy is that this is a core business approach, and maybe for regional hospitals that's the way that it needs to be highlighted and described, and potentially looking at upskilling a wide range of pharmacists or potentially other health professionals to be able to do this as part of their day-to-day work. The challenges are staff turnover, and certainly highlighted particularly for pharmacists that pharmacist turnover seems to be quite high in regional and rural hospital services, more so than even medical staff. The nursing staff seem to be quite consistent in those facilities. So how do you maintain that depth of knowledge when you've got people coming and going to make sure that they've got the confidence and the skills to be able to provide that advice for each of their patients? Health professional confidence, as I've got there. And the last challenge there, I think, is evidence of impact. So if you are part of, you would be doing accreditation, and the surveyor comes to you and says, tell me or show me your AMS program, are they going to be willing to accept that you say, well, this is core business, and come around and follow our pharmacists around and they'll show you that they think about this for every single patient? But how do you show that evidence of impact if it is part of your core business? So that really brings me to the conclusion of the presentation. In there, I've just summarised the strategies that have come up from those core themes that I've highlighted. So certainly it's exciting that there's a list of strategies that potentially could be looked at for the next phase of the research and how that could be developed. And as I mentioned earlier, I certainly would like to hear from anyone that perhaps has done some of these things already and would be willing to share their experiences. But certainly the challenges are quite long as well in terms of how some of these things could be approached. So in conclusion, the culture of independence amongst regional and rural clinicians, it needs to be respected. It's something that's been a part of how they've had to provide their service for long periods of time. So it needs to be worked with rather than against. Acknowledging that the local environment influences antimicrobial decision making, both from access to therapeutic drug monitoring or microbiology results in a timely way, but also resistance patterns are particularly important to understand. Using standardised AMS messages about how you tailor your antimicrobial choice according to microbiology results might not be as easily applied in regional hospitals, so needing to think through how that is described, and that potentially approaching AMS as core business may build resilience in the program. So I'll conclude there, and again just wanted to acknowledge Tom Schulz, who was the facilitator for the focus groups and did an excellent job in engaging everyone that was involved. So thanks to Tom, and open for questions. Thank you.
I think we might, well, I just think it's very relevant. Thank you. That was fantastic. And we might leave the questions till after Kudzai